Greetings, my name is Lindsay Ma. I'm a rising intern in internal medicine. Today we'll be covering sepsis, how to initially diagnose and manage it. The target audience for this talk is clerkship level medical students, and let's see what we can learn today. To start, we know that mortality from sepsis can be as high as 10+%, and if sepsis is accompanied by shock, mortality goes up to 40+%. And as clinicians, we can give patients a fighting chance by diagnosing and treating sepsis early. In fact, for every hour of delay in antibiotic administration, there is an 8% increase in mortality. So let's talk about how to diagnose sepsis, and then we'll talk a little bit about initial management. So the first thing we'll want to figure out is if they have sepsis at all. And in order to determine that, we have SIRS criteria, which can help us get on the right path. So the SIRS criteria include a few things, and we are looking for patients who have greater than or equal to 2 of these. These are vital abnormalities such as tachycardia, tachypnea, temperature abnormalities can be too high or too low, as well as white blood cell count abnormalities, which can also be too high or too low. Just because a patient has 2 or more of these doesn't mean they automatically have sepsis, though. They need to have a known or suspected source of infection. Because some of these vital abnormalities that we've talked about here can occur due to non-infectious causes, inflammation, for example. So in order to figure out what sources of infection they could have, it's helpful to think systematically from the top of the head to the bottom of the feet. So I usually think from the top would be brain, then another large system being the heart. We have the lungs, GI system, GU system, and then going back broadly to systems that cover the whole body would be blood or our vasculature, as well as skin. So let's say a patient has tachycardia, heart rate of 110, and a respiratory rate of 25, and then they have a new cough. That would help clue us into a potential lung source of infection, and we'd call this patient septic until we're able to rule it out. So sepsis until proven otherwise. The last piece to determine here is whether they have septic shock, which is sepsis plus organ dysfunction. The way that we determine if there's organ dysfunction is to assess for the following several things. It can include a lactate greater than 2, an indicator that there's been tissue injury. It could be based off of a creatinine greater than 2, indication of kidney injury specifically. They could have a T-bili greater than 2, platelets less than 100, suggesting coagulopathy, and then altered mental status, hypotension, and then hypoxia, and lastly, INR being elevated, or APTT greater than 60, also coagulopathy based. Some of these items you'll recognize are not specific to septic shock and can occur due to other causes. So a patient with AMS might be having altered mental status due to, lack of sleep even. And so we have to take these into context of the patient's full clinical picture. Okay, so now that we've distinguished between these three, let's talk about a example case and how we would stabilize and initially manage this patient. So we can use the same patient as before. It's a gentleman who is 65 years old, has elevated heart rate, elevated respiratory rate, and you don't have labs back yet to know whether they have a white count, but they do have a new cough. So you've diagnosed them with sepsis since you're suspicious that their lungs are a source of infection, and they've met the SIRS criteria. You want to go assess them, and their mental status is stable, their blood pressure is okay, and all of the other labs that you'd assess for septic shock specifically are not back yet. So let's start with some initial stabilization. I always think about ABCs whenever we're talking about stabilization. This is not specific to sepsis or septic shock. We've kind of already assessed their airway and breathing because he's talking to us and able to interact. If they needed supplemental oxygen, you'd want to give that. PRN. And if for some reason they needed mechanical ventilation, you'd want to acquire that as well. The next thing to assess is circulation. And if they don't have IVs in place, we'd want to get 2 peripheral IVs, large bore, ideally, in case you think you need to transfuse blood products or give fluids. And then plus minus on a central venous catheter. Not all patients need this, but if you anticipate having to give large volumes of fluids, this is something to consider. And if this patient needs a central venous catheter, they probably need to go to the ICU. In terms of initial therapies, once you've stabilized them, we'll talk about early goal-directed therapies. So there are 2 big categories that fall into this early goal-directed therapy you may have heard of. The first is fluids, and the second, as we alluded to, is antibiotics. These are critical, and many studies have been done to show that early administration of these things improves mortality. Specifically, if you can get 30 cc's per kg of fluids in within the first 3 hours, this is the gold standard to meet. Additionally, for antibiotics, we want to get things that will cover our pathogens broadly. So one would be vancomycin. And then the other one would be piptazo. These you want to give within 1 hour of identifying this patient, and plus minus on other antimicrobials based off of patient risk factors such as being immunocompromised or exposure to weird fungi. Vancomycin is going to help us cover gram-positive bacteria. There are 2 in particular that are frequent culprits. The first is Staph aureus, and the second is Strep pneumo. Vancomycin will help us cover these 2, and even some of the resistant strains such as MRSA. We'll also want to help cover for gram-negative bacteria, and so we use piptazo for this. And the 2 typical culprits are E. coli and Klebsiella pneumoniae. After we've administered these things, we want to get labs and imaging. There are 5 must-get labs, so let's talk about them. The first would be something to tell us about lactate. You can get this on a VBG. The second is a CBC, telling us about white blood cell count changes, platelet counts. We'll want a CMP, can clue us into LFT abnormalities, elevated creatinine concerning for kidney damage. We also want to get coags to tell us about coagulopathies. And then we want to get peripheral blood cultures times 2. Those will help us to identify bugs and narrow antibiotics accordingly. There's also one must-get imaging study. That would be a chest x-ray. In this case, in the patient that we talked about, it's super important because we're suspicious for some type of lung infection. And so this chest x-ray could help rule in or rule out a pneumonia. The next step is to consider what monitoring you'll need in these initial phases. So in terms of lines, we talked about plus minus on a central venous catheter, and same with plus minus on an A line or an arterial line. This will kind of depend on how severe the sepsis is and goes beyond the scope of today's talk. The next thing is to consider clinical signs you want to monitor. So we want to make sure their MAPs are greater than 65. You can get this off of regular blood pressure cuff. Want to make sure that the urine output is maintaining above 5 cc's per kg per hour, because this can be a sign of their kidneys not working well. Want to monitor normal vital signs such as heart rate, respiratory rate, temperature, pulse ox, and then mentation. All right. And although we got some initial labs, having labs on a regular basis to start Q6 hours can be helpful to tell us the trajectory of this patient. Are they improving? Are they getting worse? Do we need to escalate care? Every 6 hours, we'll want to repeat lactate, something to measure platelet counts, typically a CBC, and then something to monitor LFTs, typically a CMP. And then every 48 hours until clear, we'll want to monitor peripheral blood cultures. Get new ones is what I mean. We'll get them times 2, and if there is a prior set of blood cultures that hasn't grown anything in 48 hours, then you can discontinue these regular peripheral blood cultures. Lastly, plus minus on monitoring CO2 levels in the blood on an ABG or VBG. This really depends on whether or not the patient is looking hypoxic or hypercarbic, and in order to trend and support the patient. So to recap, patients with vital abnormalities that meet SIRS criteria should be assessed for sepsis by figuring out if they have a known or suspected source of infection. If they meet both of these, then they are diagnosed with sepsis until proven otherwise. If the patient also has signs of organ dysfunction, we categorize them as having septic shock. In either case, if they have sepsis or septic shock, we'll want to stabilize them by giving supplemental oxygen or even mechanical ventilation. We'll want to make sure that they have 2 peripheral IVs and ways to infuse large volumes of fluids if needed, such as using a central venous catheter. Initial therapy should include 2 mainstays, which are fluids and antibiotics. And it's important to get these in really quickly. Fluids, 30 cc's per kg, should be administered within 3 hours of identification, and antibiotics should be broad and cover these big bacteria that we think about. Initial evaluation should include 5 must-get labs and 1 must-get imaging. These evaluations should not delay your ability to start early goal-directed therapies. And lastly, we'll want to monitor the patient for whether they're going to improve or get worse and require a higher level of care. Your time is precious, so thanks again for joining me in this talk. Until next time.